So thanks for joining us today. We'll go ahead and get started with some introductions and then get into the meat of the discussion. So today, Partnership to Improve Patient Care is really excited to have Josh Seidman joining us from Avalere Health, a group that has done some very meaty and great work in the context of alternative payment models and lots of other issues. But today we're really going to be focusing on alternative payment models, what they are, why patients need to care, and are very excited to have everybody here joining us to have this discussion. So just about myself, I'm the Executive Director of the Partnership to Improve Patient Care. My history is I started on Capitol Hill, moved into a law firm, and now I found myself in this world of advocating on patient-centeredness, which has been really exciting. And for me, I think the most exciting part has been learning about this issue from our fearless chairman, Tony Coelho. He's the chairman of the Partnership to Improve Patient Care, also known as PIPC. He's also a former congressman who authored the Americans with Disabilities Act, and some of you are more familiar with him as an activist for disability rights and for patients. And he comes to these issues from the direct perspective of being an epilepsy patient. What Tony will often say when he is speaking in public or even in private is that as a patient, he is not average. And so when we start to talk about how we healthcare to patients in a manner that looks at treating, average types of patients, he's a strong advocate that we need to be treating the individual patient. So PIPC was founded back in 2008. We began a coalition focused on patient-centeredness and research, advocating for the creation of the Patient-Centered Outcomes Research Institute. For those of you who are not familiar, PIPC was created in the Affordable Care Act to do patient-centered comparative effectiveness research. And they've really done, I think, a stellar job of changing the culture of research. So now PIPC, as to be sort of the leading stakeholder hub for patient-centeredness and from research, payment, and delivery of health care. What we have from our experience in advocating for the creation of a patient-centered research institute is that those same principles of patient-centeredness really apply across the board in health care. Our MIP has now grown to, I think we're at 53 advocacy groups. We've another 15 to 20 non-member groups in our roundtable discussions and have really tried to earn the reputation as the authentic voice of patients. And so these are a few of the places where you'll find Tony talking about what it means to be patient-centeredness in the media. We have found that folks are talking about being patient-centered and what patient-centeredness means, but it has a consensus definition behind it. And something I think we've identified as a real goal is to put some teeth behind the meaning of patient-centered and not just have it be a term that's being thrown around by policymakers and others to meet their needs. So this discussion is several-fold. First, we are strong advocates for PIPC. When PIPC was being implemented, we strongly advocated for them to shift to a targeted funding process that engaged patients from the get-go, that really brought together the patient voice to determine what research matters and how to do it in a way that captured the outcomes that matter to patients so that they could really use that information in their decision-making. We also be in for meaningful patient engagement strategies within research, so having patients engaged in the research design in particular has been very important, and we're finding too, as PIPC is looking at having research findings being disseminated, we've been strong advocates that patients need to be part of that dissemination strategy to make sure that it is successful. So again, we advocate for PIPC and we advocate for principles of patient-centeredness. So often you'll find PIPC doing comments on things coming out of Capitol Hill. And something we really dug into is patient engagement and alternative payment models. Now that we have a model for engagement at PCORI, where they're doing patient engagement and really changing the culture of research to value patient engagement, what we have determined is that kind of model needs to then be looked at throughout the healthcare system. In one place where we've identified that could use is the implementation and development and evaluation of alternative payment models, which are being implemented at CMMI. And that we have Josh here because he is an on alternative and is going to be able to tell us a little bit about where to plug in. So I want to understand the changes in how Medicare and Medicaid pay for and value services. We want to talk the implications that has for patients and identify how patients can really make a difference in that process. Patient engagement and having patients at the table for these discussions is going to be extremely important, particularly this year as the administration is really stressing to alternative payment models within Medicare and Medicaid. So I'm going to turn it over to Josh and let him educate us on what's going on with alternative payment models and how the patient voice can be heard there.
Great much, Sarah. I'm really excited to be here. Issues are really important right now, and it is incredibly important for patients and patient advocates to be fully engaged in this process because, as Sarah said, really will shape how payment evolves in the future. And payment drives a lot of what happens, and I think it's really important that when we're thinking about a value-based payment system that we are really engaged in ensuring that defined from the patient's perspective. I'll go through really trying to give people a sense of how alternative payment models are developed and implemented and evaluated. I'll talk a little bit about the specific opportunities and the specific pressing issues that are involved, things that are going on in the environment, and talk a few of the kinds of models, and then we'll specifically focus in on the implications for patients. There will be plenty of time for discussion. I'll really look forward to that. I'll kind of present things, at a fairly high level, but we'll more than welcome any deeper questions as we get into it. So first, let me just start with a sort of set up with setting the right now. So yeah, the slides seem to be jumping around. So first, to talk about really is the Center for Medicare and Medicaid Innovation. When the Affordable Care Act passed, there was $10 million that was set aside for CMMI. The really important thing here is that CMMI was designed to ensure that as we provided their access to people for health care, that access coincided with the other issues for the AAA. So what I want to sort of emphasize here is that there are different ways that CMI is trying to shift from fee-for-service or turnstile medicine to more of a value-based payment environment. The goal here is to think about how to encourage providers and others to think holistically about accountability for the entire health of a population. And so that's really the aim of these models. So that includes things like accountable care organizations and bundled payments. Bundled payments are episode care. I will talk about ACOs in a moment. Pay-for-performance programs, which are really something that has been evolving over time and really focus on trying to ensure that payment is not just for service, but actually is for the performance that those providers produce. And so there are a lot of things that have been in place and have been growing that have led us to the preface of the value-based payment environment. And then things like patient-centered medical homes, and really a whole series of other models that are being tested out by CMMI. And I'll talk about those in a moment. The other really important piece of legislation, so if you think of there being a lot of important ground that was laid before the Affordable Care Act, it came along in 2010, and then 5 years later, there was a passed called MACRA, the Medicare Access and Chip Reauthorization Act. This was really a landmark bipartisan bill that really changes the future of Medicare physician payment. The idea here is to from what had been started 20 years ago, which was just to kind of try to growth of physician payment. It was through something called the Sustainable Growth Rate, or the SGR. And every year there was an SGR path for a doc fix, this sort of Washington go about how to make sure that we didn't have these dramatic reductions in physician payment. Well, every year that happened, but it didn't, when these patches were made, they didn't address the underlying issues about making sure that we link payment to value. And so MACRA is an attempt to do that. And so there will be a lot of opportunities to drive new payment models through MACRA. And so we'll get into that in a moment. So let me go to the next slide. What I want to emphasize is that there is a very determined right now to change payment in terms of their fee-for-service basis and moving them to these alternative payment models. And almost exactly a year ago, the Secretary made a bold statement about where she wanted to go. And that was really to move half of all Medicare fee-for-service payments into alternative payment models by 2018. And the point I want to make on this slide is that of the Medicare fee-for-service payment, nearly a third of all Medicare beneficiaries are already enrolled in Medicare Advantage or Medicare Managed Care. And so what we're talking about is half of the two-thirds of those two-thirds of Medicare beneficiaries that are still getting traditional Medicare for service. And half of those are anticipated to be moving towards alternative payment models. So when you put it all together, you're really talking about even more than that will be in some sort of either capitated system or some sort of system that is focused on looking at a population's health. So I want to go into the details of this slide around MACRA, but I do want to make a couple of important points here. So one is that you can see the blue bar at the top of this graphic that there typically has been an update. And what is happening is that they're phasing out this update, which is the amount by which physician payment will increase each year. And in 2019, there will no longer be any automatic updates. And what will happen is that physician payment will be subject to something called merit-based incentive-based system, or MIPS. And the idea here is to create a 0 to 100 composite score to judge physician performance. There is a way that things can elude MIPS, and that is by participating in some qualifying alternative payment model. They will get a 5% bonus payment without having to be scored on MIPS. And so there's going to be increasing encouragement for physicians to fully engage in these APMs. I think that is important context. Also several other things related to MACRA, which we'll come to later, that have important implications for how providers will be measured and therefore the way in which they'll be trying to focus on engaging with patients. So let me talk now about how APMs are developed as they move forward and what the Affordable Care Act means for that. So as I said, CMMI was really designed to make sure that there was active, ongoing development of models that could drive value-based payment. They took several different approaches for this. One is that they created a number of demonstration programs around specific models that had been either conceptualized or had been around in various forms, but hadn't really been instituted in any broad way at the federal level. The two most prominent ones are accountable care organizations, or ACOs, and bundled payment, which are episode-based payments for long episodes of care. So, for example, the 90-day episode care surrounding, say, hip replacement surgery. So all the is involved in that. But in addition to these demonstration programs, there are also a whole series of other initiatives. And they are now testing out nearly 150 different innovation models. These are special grants that were made to a whole wide range of organizations to test out different care delivery approaches, different payment models, and many of these do have important implications for the engagement of patients in their own care. And they are trying to focus on ensuring that quality is improved, while cost is managed, and ultimately creating a more efficient system. Obviously, there is a lot of questions need to be addressed about how those measurements are going to be made and how to ensure quality is achieved. Now, the really important thing that I want to point here is that all these demonstrations and innovations are different than in the past. In the past, when it was testing out some new model, there was a long period of testing, a long period of evaluation. The report would be produced, and then that report would go, circulate on Capitol Hill. There'd be discussions with people in Congress, and invariably, they just led to either more demonstrations or to circulating onto some other idea. It has a very important provision in it, which is in Section 3021 of the Act, which gives the Secretary broad authority to take models that are deemed successful by the MS actuary and convert them into long payment models, to extend them either from a small local level to a more regional basis, to do something with them that allow them to really be part of Medicare's ultimate payment construct. And so if the model is without harming the quality, or if it improves quality without increasing cost, or if it does both, then the Secretary has authority to convert that. This has actually already happened last year. There was a mentioned hip replacement. Well, hip and knee replacement was really the first area where they took a bundled episode of care payment, said that for about 7 regions throughout the country, which is about 1 of every 5 hospitals, those hospitals now are mandated to participate in this comprehensive joint replacement program. And JR is now a new way for payments to be done for those 90-day episodes of care. And I think we can expect that there will be other things that will come along similar to that in the near future. So a little bit about what all this means for patients. And the way I want to start off is giving some context as to how providers might think about these new models. So the first thing is to think about the time horizon that provides approach this. The time horizon, what I'm really talking about is whether it is a single point in time. So think of a single visit, or on the hospital side, a single inpatient stay, or whether that gets extended so that the provider is now concerned about, say, a 30-day readmission where they're concerned about the post-discharge care and in preventing deterioration of that patient that causes a readmission. Or, as I mentioned, the 90-day TJR, which requires them to think about managing that patient's health on an ongoing basis for 3 months. Or, there is something, the oncology care model, and that's really goes for a 6-month. But of course, that can go up to a full year or potentially even beyond. And so the length of time that a provider is responsible and where payment encapsulates that with time makes a big difference in how they think about their approach to care. There also are a lot of differences in how providers approach care depending on which services they are accountable for. So they may be accountable for the visits in their clinics. They may just be accountable for what goes on inside the hospital. It could involve a whole series of post-acute care services. It may involve drugs, the very treatments that are required afterwards. So this is a variable that is really is something that can vary tremendously depending on the payment model. Then a really big difference between accountability for a particular episode of care, and so that is, again, it could be just something as simple as a simple encounter with the delivery system, or even a bundled payment where there is some sort of triggering event, right? So even with a CJR where they are accountable for an extended period of time, until the patient is that treated, the program has no accountability for the health of that person. Based payment models are very different in that some sort of entity is responsible for the health of that person, and any costs that are borne for that person over the course of the year then are a part of the accountability. And that really changes how a provider might think about the way to approach the population, because rather than just reacting to what happens to that patient and then acting based on some triggering event, there's a strong incentive for providers to take a much more proactive approach to anticipate what the needs are of the patient and to try to address them. Now, the thing that is, as these different payment models are considered, they have a big impact on who is at risk and has control. Historically, in a fee-for-service environment, the payers bear most of the risk. But to bear the risk, there are a lot of controls that they are going to place on providers and in many patients, because they want to ensure that there isn't, the providers are following certain protocols, certain pathways, certain approaches to care, because the payer is on the hook for the cost of care. But it transfers to providers, provide then also more control, because payers will transfer the control along with the risk. It really can change the dynamic in terms of who drives decision making. What about what value is? I also want to, as you're looking at this graphic about pay engagement and how it drives value, I want to be clear that this is sort of an external view of patient engagement. This is how somebody aside from patients might think about the value of patient engagement to them. I think that I just want to be clear that this isn't my view of what patient engagement is. It is the way that other organizations and external actors are thinking about the value of patient engagement being successful in these alternative payment models. And these are all things that can happen as patients get more engaged. So, for example, decision-making can help to ensure that the decisions that are made by patients in collaboration with their clinicians are appropriate for their values and preferences relative to the evidence that exists. The engagement of patients in their care after they're discharged from the hospital really has a big impact in their ability to improve health, to rehabilitate, and to that they don't unnecessarily need to be related to the hospital. There are many other things, as you can see from this, where engagement in one way or another, whether it's to a treatment regimen, whether it is in the engagement and use of preventive services, or whether they just have a basic confidence and efficacy around their ability to manage their health. All of these things can help improve the ability of providers to succeed in these alternative payment models. And having a focus on this has been a big part of the strategic goals of organizations in these new payment models. What I wanted to mention here is that these new models, and this is particularly true of MACRA, have a lot of specific elements that are driving patient engagement. So in MACRA, there's an emphasis on a series of clinical practice improvement activities that really are going to be trying to drive shared decision-making, trying to improve care coordination, really improve 24/7 access of patients to their clinicians and to the information that they need in the future. MACRA has a lot of specific goals around the development of patient-reported outcome measures. So they're going to really be trying to better understand patient experience and the ways that patients, the quality from the patient's perspective. And I'll talk a little bit more about that in a moment. There's emphasis on greater transparency around the services and the costs of what providers deliver to patients. And there's emphasis on ensuring that there's greater access to technologies that can help support people away from the sort of traditional clinical experience. When we talk about patient-reported outcome measures, there are several different aspects to that. Probably the most common one that people think about is patient experience and satisfaction through an instrument called CAPS. That has been something that has been fairly widespread. It's used in most Medicare payment programs as well as many programs in the commercial sector. And ACOs, for example, some of their 33 performance measures came from the CAPS survey. And so that area is reasonably well developed, although there are always efforts continuing to try to make it even more robust. But then several other ways that patient-reported outcome measures are being developed or considered for future payment models. So around functional status or quality of life. So as an example, we were talking about CJR, that Comprehensive Joint Replacement Program. One of the reasons why that was one of the first programs to turn into a mandatory payment program was because there are reasonably well-developed measures around the functional status of patients after they've had a hip or knee surgery. A very good example where real important outcome is well, can I walk again? Can I exercise again? What is my ability to function in daily life? And so JR actually provides an incentive for hospitals to implement these joint placement functional status measures. We can also measuring patient activation and engagement. There's important research that shows that as patients get more activated and engaged in their own care, that they perform better on a whole series of measures that span the range of the ability to manage chronic conditions all the way to their self-efficacy and other things. There is then things around what people's symptoms and pain reporting. This would be very important in managing conditions. As a parent of a child with asthma, the ability to communicate with my pediatrician when during, say, the spring pollen season, when my child's asthma is acting up, is really important to me. Right now, I don't have a very good way to do that. And then measures of decision quality. There are measures that really understand a combination of whether the patient has been provided with adequate knowledge to make a decision, but also, just as importantly, were their own values and preferences considered in that decision-making process. There are many that have been that are actually going through the endorsement process by an independent body, the National Quality Forum, right now related to that. So what I'm going to do now is sort of just conclude before we get into questions with a couple of things that we might want to discuss. One is really just how important it is for patients to be engaged in the development of alternative payment models. It is really important that there is full engagement of the patient community, because these models are going to move forward in one way or another, and patients have a real opportunity to help shape them. The thing I really want to emphasize is that we're just talking about all those different patient-reported outcome measures, or measures that really get at what patients' needs are absolutely essential, because all these models in a value-based payment system are going to be driven by some definition of value. And if we do not have definitions of value that fully represent how patients think about value, we're not going to fully understand that. So I think I'll stop there and really look forward to getting into some good discussion.
I had to take myself off mute. But that's actually really helpful, and I think that the points that you're making at the end are just so valuable. When we think about patient-reported outcome measures, it just strikes me. I know in a lot of the discussions that we have had as PIPC during roundtables, and I know, Josh, you participated in roundtables with us, what we often hear is that patients weren't necessarily, it could be a patient-reported outcome measure, and that's wonderful, but the question then becomes, were patients actually engaged in the development of that measure? Did it come from some other stakeholder speaking on behalf of patients? And one of the things that PIPC has really prioritized is that, as we talk about whether it's the development of the measures, whether it's about developing the shared decision-making tool, and here talking about the development and implementation of alternative payment models, it is so important for patients to be at the table in that development process, because otherwise what matters to patients may not necessarily be incorporated. So I think, 2016 stands to be, I call it a foundational year. A lot may not happen legislatively, but there are a lot of opportunities for us this year to make a difference. And one of the things that we often talk about at PIPC is creating a culture of patient engagement. And what for us, it means formalizing avenues to provide meaningful voice to patients in research and the creation and testing of APMs, ensuring quality and value definitions are driven by patients, informed choices from a range of clinical care options through shared decision-making, empowering patients with accessible, understandable evidence to achieve their personal treatment goals. And on that third bullet, that's really, to me, and that's where we talk about, there's a need to link this patient-centered outcomes research, particularly the kind of work that PCORI is doing, to making tools that actually empower patients and make them more patient-forward and patient-focused. A lot of times you find that these shared decision-making tools are really much more geared toward provider clinicians and help to have them engage their patient, but not necessarily tools that patients can access directly. And avoiding a singular focus on cost containment and protecting against a one-size-fits-all approach to patient care. And that is a talking point that Tony Coelho, our chairman, often emphasizes, is that, he is not average patient. Most of us are not average patients. And so, creating a world where patients are accessing, are being driven toward one-size-fits-all treatments doesn't necessarily suit all patients. And, of course, support access to medical advances. And so a challenge that Josh, I think, had just well articulated is, moving to what we're calling now a value-based healthcare system. I think the real question is value to whom? And for the patient should be reflected in alternative payment models. Policy should support patients to be active and informed participants in their own care. Shared decision-making tools should inform patients and caregivers on all treatment options, as well as the impacts based on their individual needs, preferences, and outcomes, and there's one algorithm for value. And something, just in terms of how CMS and HHS is driving these alternative payment models that Josh described, he did a real job of talking about the Better, Smarter, Healthier initiative and the goals that HHS has for more patients, and I think he was absolutely right that they're really targeting the fee-for-service population, but really more patients into these alternative payment models. And if they're going to be doing that, we have our work cut out for us to make sure that they are truly patient-centered. And something we've also created to support this effort is something called the Healthcare Payment and Learning Action Network. We're calling it the LAN, L-A-N. So sometimes it's another acronym because we don't have enough acronyms in healthcare. But the LAN, or the Healthcare Payment and Learning Action Network, was created to kind of be a place where we share information about alternative payment models. What is an alternative payment model? What does it look like? What are its characteristics? And I think the hope is to drive more and more systems and providers to join alternative payment models and to create alternative payment models. And so this Healthcare Payment and Learning Action Network has created several work groups. Recently, they created something called the APM Framework Work Group. That was the first one out of the gate. Then the Payment Work Group, and they're working on one for clinical episodes and others to be announced. I would point out that, there are a lot of payers who are participating in this effort, and payers are clearly a stakeholder in this discussion. Something that I've really pushed at PIPC is that the patient voice also needs to be front and center. If you look at the white paper that came out of the APM Framework Group, they talk about sort of, what are the pillars of patient-centeredness, and I was very surprised, despite a lot of, I think, comments to the contrary, they still include things like cost-effectiveness as things that are considered to be pillars of patient-centeredness. And, I think it's a strong indication to me that there aren't, the patient is not necessarily front and center, or hasn't been front and center in that work. So something that we've done, we're participating in at PIPC is the Consumer and Patient Affinity Group. And that is a group that is also considered sort of a subgroup of this LAN effort, where patients and consumers come together and provide feedback to the LAN. So my hope is that as that process evolves, that we will have opportunities to determine criteria for what it really means to be patient-centered. And so from PIPC's perspective, there are several things I think that make an APM value-based. And when I value, I mean value to the patient, right? The considerations including the range of endpoints, care outcomes, and treatment goals that matter to patients, factors influence differences in value to patients within populations, different perspectives and priorities between patients, carers, people with disabilities, consumers, beneficiaries, how people want to be engaged in their healthcare and treatment decisions, and the characteristics of meaningful shared decision-making to support this. And then, of course, patient engagement at the policy development level. And CMMI has recommended, and we've kind of come up with this list from conversations that we've had in roundtables. And if you look on our website, you can see the summary from all of the roundtables that we've done over the last few years. The first, I'm going to talk a little bit more about on the next slide, but we are strongly advocating for the creation of a patient advisory panel within CMMI. Also to identify and subsequently clear patient-centeredness criteria in the approval and evaluation of APMs. The statute actually talks about patient-centeredness criteria and recommends the use of those criteria in evaluating APMs, but we don't have those criteria yet. Really, a pathway for their development, including patients and providers in the development of quality improvement and measurement, develop evidence to practice with patients. That gets a core, translating good evidence, such as what is coming out of patient-centered outcomes research to shared decision-making, using definitions that are centered on outcomes that matter to patients. Value has become, as I'm sure many of you know, a loaded word lately. There are lots of value tools or value assessment tools out there, but what we really try to focus on is what are the outcomes that matter to patients that should be looked at as the measure of success of any type of payment model. And then APMs that engage patients and use real shared decision-making and all treatment options, impacts, out-of-pocket costs, et cetera. One thing I've gotten a lot of feedback from stakeholders on is that real shared decision-making means that patients should have access to not just the treatment options that are covered, but all their treatment options so that they can make an informed decision and determine, for instance, if they find something that is just much more akin to their values, that they have an opportunity to try to get access to it. And then on providers the flexibility to tailor care to an individual patient. But that requires us to also have a process for identifying patient preferences in the care planning process and using shared decision-making to achieve the goals of the patient. So one patient advisory panel, this is something that we came up with because the absence of patient-centeredness criteria for measuring the success of these alternative payment models, which, as Josh described, have the potential to become broader Medicare policies, strongly advocating that CMMI, the Centers for Medicare and Medicaid Innovation, create an advisory panel of patients would the patient-centeredness criteria that are measured against, that helps CMMI and its contractors in evaluating APMs, develop the required criteria, and connect the CMS staff with the broader patient community. There's a link that a patient advisory panel could do. I know one of the frustrations that we've had in participating in some of these conversations, and it sounds like there's actually some real concerted effort at agency level. They want patients to provide input. And I think the struggle has been, though, that there hasn't been a lot of help patients help you, right? We often say this to CMS, that if you could help identify the places where patient input is most needed and warranted and show patients how their input is being used, it would really help, because I think a lot of times patients you look at these big regulations coming out and it's intimidating, and sometimes, even when you read through it, it's not clear where the patient voice could be inserted in a meaningful way. So something that I think we really want to look at is this patient advisory panel as a pathway for making sure that we're asking patients the right questions and getting the information we need to make sure that alternative payment models are advanced in an effective way. And, obviously, we'd love you to join PIPC if you're not already a member. And this Payment and Learning Action Network is an opportunity to really talk about what it means to be a patient-centered payment model. And we encourage folks to join that and to join us and trying to explain to this group what it means and help make sure that patient-centeredness criteria are part of it. And then, of course, advocate to Congress to reauthorize PCORI and to support patient-centered CER.